Okay, so my clunky title of my talk really kind of tries to describe some of the work that we've done in North West London Park, working on a particular project around sickle cell disease, and this is a project that we've involved patients, carers, academia. So I'm going to take you through some of the background to that project and some of our results, some of the data that we've used, and I've tried to identify the data sources that we've used so that everyone's aware of what type of data I'm talking about. So just going quickly through the objectives of my talk. As I mentioned, is that I want to talk about sickle cell disease and the project that we've been doing in North West London, and specifically talk about the use of HES data for that project and cells data. So I'm not going through the mechanisms of how that data is generated, and hopefully that will come out today somehow. Also wanted to just briefly touch on the role of patients in our project, because patients represent our project through direct patient contact, but also through voluntary sector organisation that was an advocate for the patients. So they were directly involved in generating ideas for this project and delivering the project. And also I just wanted to describe some of the ongoing the opportunities for ongoing evaluation and implementation using this data at primary care population health level. So this is a diagram that I created to represent projects that we formed 2.5 years ago. So it involves both primary and secondary care professionals, but also academic primary care and public health. It involved public health professionals from the PCT, GPs, commissioners, the Imperial College Business School, and at the centre, the patient and carers, as I said, that were involved directly with the project, but also supported through the Sickle Cell Society, which is based in North West London, but is a national charity. And they all came together through the CARP programme, and we united, as we say, through quality improvement methodology and techniques that we all were taught and used as part of this project. So moving on, one of the first things that we understood is that emergency admissions are a problem across the board, but particularly for this patient group, that we knew locally that patients were using emergency departments as opposed to using their primary care GP services. So we want to understand what impact that was having nationally and locally in terms of emergency admissions, but also to understand why people were using emergency departments rather than their primary care services. So just to go through the admissions first, what we did is we did a national sort of study using HES data. We looked over 9 years at the rate of emergency admissions nationally, and you can see this trend here. It's, like probably a lot of emergency admissions, it's going up. So that gave us some kind of idea what was going on nationally, and then we wanted to look more locally in London, and it's a bit stretched, this image, but we mapped out for the London boroughs where the emergency admissions were for a particular year, which is the last year that we had data for, which is 2010-11. And I don't think there's a pointer on here. But the North West London Park covers the top left-hand corner of that map, and you'll see that there's a dark blue, one of the boroughs is dark blue, and that's Brent, for those of you who aren't familiar with the map of London. And that was the area we were particularly interested in, but we noted that that wasn't the highest in London, but it gave us some context of which we worked in. And so moving on from that, we also looked at economic data. So what was the cost of these admissions nationally and especially in London? So I won't go through all the data, the slide in too much detail, but needless to say, we used the same HES data because it's attached to HRG codes, so we could work out, we know what the cost of an emergency admission is for sickle cell, and we particularly focused on sickle cell with crisis. And we also know that there's a trim point, so it's 9 days. Anything over 9 days for a sickle cell patient with crisis that's admitted costs additional money. And I'm not going to go through the specifics of the data. I'm not an economist, but we had an economist help us with this. So this is the data. So in 2010 and 11, it cost at least £8.5 million for these admissions. These are emergency admissions with patients with sickle cell disease that were admitted for crisis. So, I mean, this gave us, again, it doesn't dissect out exactly the details of those patients, whether they should have used the emergency department or whether they shouldn't. And that's not what this was trying to do, it was just giving us a context to work within. So as I said, it's £8.5 million, at least £8.5 million for England. And then looking at London specifically, it's at least £6 million. And again, in London it's about another £500,000 when you add on the patients that stayed longer than 9 days. So that was all done using HES data. And then going back to Brent, we wanted to look more locally, but it was quite difficult to get HES data for various reasons. So the PCT provided us with SARS data, which we used to do the analysis. So I'm going to take you through one example on here just to kind of explain what we've done. So you'll see on the left-hand side there's practices A1 to A13. So those practices formed a group called the Harness Group within Brent. And those GPs were particularly keen and interested to know about how they could reduce emergency admissions for their patients with sickle cell and how they could provide better primary care services for their patients. The other 37 practices were outside of that group, but we wanted to look at what was going on there as well. So just taking practice A13, as you can see there, that data is over a 2.5-year period, as I said, provided by the PCT through SUS, and it splits the number of admissions by the length of stay. So we were particularly interested in those patients that were admitted for a very short length of stay, so that's 1 day or less. So that's the blue column there, and you can see that there are approximately 13 admissions within that 2.5-year period of where patients stayed for 1 day or less. And the other admissions, so that would be approximately 30 admissions were for longer than 2 days. So that gave us a really good insight into what was going on in the practices. And although I've anonymised them here, we were able to take this to the Harness Group and say, this is what's going on in your local area. And in some ways, I mean, it's a really, really crude sort of quality measure that we talked about earlier. But what is clear from here, it's not been standardised because we didn't want to explain the variation, we wanted to understand the variation. And I think that's often people rush in and standardise and say, you know, we need to compare like for like. But actually what we wanted to do here was have that conversation with GPs and say, did you know that this number of patients were being admitted? And what can we do about it? So moving on, as I mentioned, what we also want to do is understand the patient's barriers to using primary care services. So we held a number of focus groups and surveys with patients with sickle cell and their carers in North West London, and this was where the Sickle Cell Society was particularly useful because this approach made it wasn't academic, so it wasn't the NHS that were asking these questions, but it was through the society, and it was their support that helped us get a range of stakeholders, which I guess they'd be called hard to reach people, but we managed to do this. And you know, I'm not here to talk about this, but I just thought it was really important that we touch on it. And these were the sort of areas that came out from those discussion groups and those surveys that were important for patients. And some of them we can deal with at a local level, and others are a bit more difficult. So, but from this information and from what we know about emergency admissions and primary care use, we developed a package of interventions for use in primary care. And all this is done in conjunction with the GPs, it's done in conjunction with the university and the healthcare providers and the PCT, as it was then. And so just quickly touching on the intervention, this was around training and support for GPs to improve their knowledge and understanding of the standards of care for sickle cell disease. But also, there was a technical component which was a GP template. So this template sits within EMIS and it collects data for every patient that's got sickle cell disease and brings all that together for the GP in a management plan. And this was really useful because we didn't really understand what was going on in Brent in terms of just knowing how many patients with sickle cell disease there were, what services they were accessing. So this template allowed us to collect that data. And as I mentioned, that this template included information around you know, who had sickle cell disease, what type of sickle cell disease they had, what the demographics of those patients were, where they were having vaccinations, what other healthcare services they were using, so whether they were using emergency department, urgent care centre, outpatient psychological support. And now this data is being routinely collected and assessed to understand the impact of the intervention, the training, and the support that GPs have received on that. And obviously we've done some work with the Sickle Cell Society promoting the use of primary care for patients with sickle cell disease. So I think that's all I've got to say. I think what was important to understand is that by using data, you can use it as a driver for change. It can really, and if you've got costs associated with that, everyone wants to know what the value of any work is that you could potentially do. And also supporting commissioners. This isn't just about research, this is about supporting commissioners and supporting providers to provide those services. And focusing on the data element, I mean, we were very fortunate with this collaborative group that we had access to HES data through the academic department, but because we work with the PCT, we had access to SUS data, and because we work with the GPs, we had access to their own GP EMIS data. So it provided us with a wealth of information. It was about how we were going to use that. And again, you know, I think this is where Clark has a lot of strength. It's about generating those collaborative approaches to working across organisations that may not work together or may work at a very different level. And for us, it was important about the implementation of and design of a new intervention, but subsequently to that evaluation of the intervention. And that's it really. Just to thank North West London Hospitals, NHS Brent and the Sickle Cell Society for their work. And these were two papers that we published so far on the data aspect.